Hello, everyone. I'm Andrew Rakeman, Vice President of Research at the LustGarten Foundation. Welcome to today's LustgartenLIVE, from the clinic to the lab to you, how research led by LustGarten is transforming patient care at your local cancer center. A very special thank you to today's sponsor, Miami Cancer Institute, Baptist Health, South Florida. Today's panel of experts will discuss the role that research is having in driving the ongoing evolution of clinical care and the impact that these changes are having on patient outcomes. But before we begin, we want to hear from you. We encourage your questions, so please type them in using the Q&A box at the bottom of your screen, and we'll answer them throughout today's symposium. Today's live stream is also being recorded and will be available soon on lustgarten.org/live. You'll receive a survey after today's symposium, which we hope you will complete so we can make upcoming LustGarten Live events even more impactful and meaningful. And now, it's my great pleasure to introduce you to today's moderator, Dr. Philip Phillip. Dr. Phillip is an internationally renowned medical oncologist specializing in gastrointestinal cancers. He's director of the Gastrointestinal Oncology, co-director of Pancreatic Cancer Center, and memorial and medical director of Research and Clinical Care Integration at the Henry Ford Cancer Institute. Dr. Phillip is also professor of oncology at Wayne State University. Welcome, Dr. Phillip, and thank you so much for leading off today's webinar.
Thank you very much, Dr. Reichman, and it's a truly it's a privilege to be here today, an honor to be with you all. And again, this is, in my opinion, a very important event because it really highlights what has been happening in this field, and I want to say that it's really a very positive thing. I just want to tell you that when you talk about gastrointestinal oncology, now pancreatic cancer research and interest in doing research in pancreatic cancer has been really top and is exceeding most other aspects of GI oncology. So that's a great thing, and it's a credit to everyone, including people who are joining today and certainly my panelists. So as a medical oncologist, I really often get asked questions about many of the topics my esteemed colleagues today and myself will be covering. And the value of research is only felt when really the patients can access the resulting treatment advances and care at their local cancer center. As Dr. Reichman alluded to this in this introduction, today you will learn how this research, led in great part by LustGarten, is really impacting patient outcomes. It is now my great pleasure to welcome today's guests and introduce them. And all of them are my colleagues, and we worked together in various forms or shapes. So Dr. Anirvan Mehta is a professor of pathology and translational molecular pathology, and the scientific director of the Sheikh Ahmed Pancreatic Cancer Research Center at University of Texas MD Anderson Cancer Center. Dr. Mehta is the principal investigator of an NCI-funded laboratory dedicated to pancreatic cancer research. Dr. Mehta also serves on the LustGarten's Foundation's Translation Advisory Group. Next, I'd like to introduce Dr. Kimberly Perez, who's a member of the Dana-Farber Hale Family Center Gastrointestinal Oncology and Cancer Genetics and Prevention Disease Centers, and is currently an assistant professor of medicine at the Harvard Medical School and the Dana-Farber Cancer Institute. Dr. Horacio Asborn is chief of the hepatobiliary and pancreatic surgery at Miami Cancer Institute and throughout the Baptist Health South Florida health system. Arsen Osipov is a GI medical oncologist and program leader of the Cedars-Sinai Pancreatic Cancer Multidisciplinary Clinic and Precision Medicine Program. He's also a clinical translational investigator in the Gastrointestinal Disease Research Group and Pancreas Cancer Research Group of this Samuel Ocean Cancer Center at Cedars-Sinai. So let's start. And Dr. Mehta, let's begin with you.
Sure.
So when I began working at the Karmanos Cancer Center, Wayne State University in the mid-1990s, and I'm sure you remember at that time, we were talking about survival rates which were just under 5% even.
Yes.
But since then, tremendous progress has been made along the way. And there's no doubt that this was and continues to be driven by research that translates the scientific findings to better treatment outcomes for our patients. Dr. Mitra, can you please share with us how the panorama of pancreatic cancer has changed and evolved, touching on the decades-long road to now 12% survival rate? We have a long way to go.
Absolutely.
And while you highlight the tremendous advances made with things like newer agents, multidisciplinary care, and also, to me, very importantly, overcoming the nihilistic attitudes towards the disease, which obviously we experienced when we started our careers. Dr.
Absolutely. Yeah, thank you so much, Philip, for that introduction, and thank you to the Lustgarten Foundation for inviting me to this webinar. We're very excited to talk about this and amongst friends and colleagues here. So when you're absolutely right, when I started my training and fellowship more than 20 years ago, the 5-year survival rate was 4%. And it now stands at 12%. And now certainly 12% is not where we rest on our laurels. We have a long way to go. And this is certainly the reason why there is so much research and work going on in Lustgarten funded labs around the country and many other laboratories. This is the reason why, as you mentioned, every month, Dr. Tuvison and Jaffe and Dr. Rakeman and many of us who are on this translational accelerator group get together with the idea of initiating new clinical trials in this disease, because again, 12% is just sort of a chapter 1 of a long book. We have a long way to go. So, but with that said, I think there is some cause for celebration, having come from 4 to 12%, which is almost 3 times where we were 20 years ago. And part of that is, number one, we now have better agents to treat this disease. Unfortunately, most patients still present with advanced metastatic cancer, and there are now 2 frontline regimens that are approved, gemcitabine and nab-paclitaxel and FOLFIRINOX, which are used widely around the world, and they have enabled improvements in survival over what used to be the standard of care in the 90s and earlier. The second thing that I think has really helped improve survival is the adoption of multidisciplinary care in this disease. And you know, and all the speakers on this call know, because you see patients with this disease every single day, that pancreas cancer is likely to have better outcomes when the disease is treated as a multidisciplinary care. And that includes not just giving chemotherapy or doing surgery, but also things like supportive care, nutrition, exercise, and other things that are outside of the realm of just treating the patient. Many times in centers where patients are seen in a multidisciplinary setting, patients who were earlier deemed as unresectable are now considered resectable because there are expert surgeons and radiation oncologists who are seeing the scans, and these patients then are able to undergo a procedure that they may not have been considered for outside. And so I think that certainly has really added to the improvements in survival. When we talk about nihilistic attitudes and what used to be quite prevalent and still is, as much as, and again the numbers vary, but as much as 1/3 of our patients likely don't get the care they should receive necessarily in the community, or they're not operated on for a stage of disease where they should still be operated if they were treated appropriately. And this is certainly one of the reasons why we strongly recommend if there is an opportunity to be seen at a place where there is a high volume of patients that are treated for pancreatic cancer, because again, this is a complex disease, requires multidisciplinary care. Sometimes it is hard for a community oncologist who may see just a few cases a year to treat this disease appropriately. And that's why, for example, we strongly recommend, around the country, there are these so-called NCI designated cancer centers, both comprehensive cancer centers, which are the most prestigious designation, as well as cancer centers that are more clinically oriented. So these are around the country, and that information is publicly available on the National Cancer Institute's website. So you can look where is the closest NCI designated cancer center. These are typically staffed by physicians such as who are on this call, who see patients all the time. And we completely understand that sometimes getting to an NCI designated center may be hard because of financial issues, distance, etc. In that case, the NCI has also done a wonderful thing, which is they've created this network of what they call community oncology research programs, or NCORP, NCORP. And again, you can look up NCORP sites that are spread around the country. And these bring clinical trials to our patients in the community, even far away from sites where these comprehensive cancer centers are located. So the bottom line, the message I hope we would really like to convey to the audiences listening in is, please get to an expert who sees patients with pancreatic cancer day in, day out, because these are the individuals, such as the ones you have on our call today, who really know how to deal with the nuances of this disease. It is a complex disease. It requires multidisciplinary care, but we now have treatments available, which if used appropriately, can result in much more improved outcomes than 20 years back.
Can I just pick a couple of things you said, if you don't mind, Dr. Mehra?
Of course.
One of them is, when we talk about multidisciplinary care, we always, in our minds, are thinking of pathology, radiology, surgery, medicine, gastroenterology, medical oncology. But in my opinion, we have reached to a point where we have to also include some other people as an integral part of the team, not like someone we just go to whenever, like once a year, or to ask questions. So I think you, as a molecular pathologist, or at least someone who has a lot of interest, I think we really have to also include a molecular pathologist on a regular basis, because of the advances that have been made, for example, in genomic sequencing and NGS, and it's just getting more and more complex. So I think, how do you feel about you also being an integral part of patient management, rather than someone who is a advisor or a research collaborator? Can you comment on that?
Absolutely. And thank you for asking that question. I think it's a very important component of the multidisciplinary care of our patients. Again, as I mentioned, this is a disease where it's not just giving the chemotherapy that's important, or doing the surgery, but, pain management, nutrition, the supportive care components are so important here. And so in that context, I feel the molecular pathologist is also a very important part of this multidisciplinary care. And I don't want to sort of jump the gun here, because I know that Dr. Perez and Dr. Osipov will talk more about things like germline testing in high-risk individuals and identifying who's at risk in family members. And Dr. Osipov will talk about molecular subsets of cancer, pancreatic cancer, that we're starting to treat. But this is where people like me come in. We provide that information then Dr. Perez or Dr. Osipov will act on in the context of their patients that they're seeing. So yes, it would be wonderful. And in fact, as you well know, all of the national bodies like NCCN and ASCO have strongly recommended that every patient with pancreatic cancer undergo germline sequencing and sequencing of the tumors in order to identify some of these molecular subsets for which now drugs exist, and more are coming. And I know, again, I don't want to jump the gun here. I know we're going to talk about things like RAS targeted agents, which is the biggest enchilada. And I'm in Texas, so I have to use enchilada here. The biggest enchilada in pancreas cancer. 90% of cases have RAS mutations. We finally, after 40 years of trying, have drugs against KRAS. That is going to be the biggest thing in this disease in the next few years. There's a lot of effort going on. Again, Lustgarten is funding a lot of research into RAS and RAS inhibitors. And so I think this, for all of these reasons, molecular analysis of tumors is as much a part of the care of a patient as, for example, giving gemcitabine and nab-paclitaxel.
Yeah. No, I agree. And I didn't really want to jump into it because I know we'll be discussing this, but you, as a molecular pathologist, I don't want to get your feel for this, because I really think that that's something we have to think as we go forward. But also, Dr. Anirban, it's becoming more complex. Oncology is becoming more complex, and it's going to affect the same thing, pancreatic cancer. And at the same time, the bulk of the patients treated are obviously in a community setting. They go to their local centers. So we also have to touch on how to best inform the patients, and also how best to inform the providers and the doctors who take care of those patients. Do you have any thought about that? I mean, you're involved very much at the national level. Not everyone can come to MD Anderson. Not everyone can go to wherever we work. So
Yeah.
but
No, that's very
we
good.
have to really we have to really be realistic, because for the bulk of the patients are indeed being treated in places outside of the big centers.
That's a very good point, and I think again I suspect we will touch on this in the later conversations as well. But I think this is where education and awareness is so important. And one of the things that I did want to mention in this context is certainly there are wonderful educational opportunities and webinars that are offered through many of the national bodies that folks in the community can certainly can attend. I know that, for example, even many of the pathology organizations offer these sort of molecular testing and how to interpret results type of continuing medical education courses. But for patients, caregivers, and families, we have every month online on Twitter, we have a PANC chat, which takes one topic at a time. This is organized by Let's Win Pancreas Cancer, Let's Win PC, which is a patient advocacy organization that does tremendous work in the community and online. I'm one of the co-hosts of our monthly PANC chat, and one of the topics we discuss is molecular profiling of pancreas cancer. What does it mean to have a particular result? And so I think there are many sources now, both online and otherwise in more conventional media, that one can avail for these purposes. The key thing, and I'll end with this because we have a great panel to go to, is to make sure that the information you're getting is reliable. There is a lot of misinformation out there, and this is why I always say go to a credentialed organization or their website to learn again what is real and what is not. Again, there's a lot of potential for misinformation, and so I strongly encourage the audience who are listening in, organizations like Lustgarten or some of the institutions that are on this call, please make sure to visit their website, because that's where the information has been vetted before it's put on there. So
yeah, that's excellent. And throughout today, with the time we have today, we really like to also encourage our panelists to really ask or have some comments. So I'm just encouraging my colleagues here on the panel to really be able to add anything. For example, here with what Dr. Mehta said, and we have a number of questions that have come to us. One is a comment about palliative care, pain management, and how important it is alongside with mental health management. So, and I agree, and I'm sure you agree with that, Dr. Mehta, Dr. Anirban.
Absolutely. And that's why I brought up the multidisciplinary care, that we shouldn't just think of it in the context of drugs or radiation or surgery. It includes, palliative care. In fact, we know that I think, and again, I want to give our oncologists and surgeons an opportunity to speak, but, palliation is something that should not be equated with, terminal disease or hospice care. That is not what palliative care is. It's in fact, early introduction of palliative care and quality of life do have a beneficial effect on outcomes. This has been shown repeatedly, even in the context of pancreas cancer. So pain management is very important. Mental well-being, no question that is something, again, that can be
absolutely.
So,
Dr. Mehta, I wanted to just, Dr. Phillip, add something to that point Dr. Mehta brought up. Here at Cedars, for example, we have a multidisciplinary same-day clinic. On that day, like many oncologists, GI doctors, radiation oncology, and surgeons, actually that same day, the patients meet social workers and supportive care members. And often the feedback is they're very happy that they were able to see those patients very early on in their care to address concerns about pain, social stressors, impact on family. And actually long-term, it provides a better outcome to these patients when they see these doctors very early on in their care as a part of a comprehensive multidisciplinary team.
That's wonderful. Thank you. We just to tell people that the questions are coming, and what I'm going to do is try to fit the questions into the segments that really are relevant to them, so that we will answer all the questions. We're not going to skip anything, but we'll put it in a segment during the talks where it best fits there, when the expert will be answering them. Okay, well, I think this was great. Thank you very much, Dr. Anirban, and again, we will be going over the questions, and we'll come back to you, Dr. Anirban. You're not done yet, by the way. I'm pleased to next welcome Dr. Perez. Dr. Perez, your work is grounded in a lot of the cancer prevention and genetics. Major two topics which we always get asked by patients, caregivers, and other people we meet in our daily professional, non-professional life. So let's start with maybe talking about what defines a high-risk individual and the role of the genetic testing to look for inherited mutations in these high-risk individuals. And also, if you can touch on how best to utilize imaging and endoscopic surveillance of those high-risk individuals in the community in order to detect pancreatic cancer at its earliest stages. And again, thank you for joining us, and please go ahead.
Thank you, Dr. Phillip. This is a great opportunity to join this great group of clinicians and scientists. So yes, so let's start. This is a very common question that is posed to me when I wear my hat as a medical oncologist and when seeing patients in the high-risk prevention center at Dana-Farber. These are the patients that we're looking to see and help define their risk. So I'd start with just who would be considered in this high risk category. As we know, the risk for the average person to develop pancreatic cancer has been described as low as less than 1% in their lifetime. So what we've defined as high-risk individuals are patients who have a family member with a first-degree family member that has a diagnosis of pancreatic adenocarcinoma. So first degree means sibling, child, or parent. And that can, with that relation, can increase one's lifetime risk for pancreatic cancer to around 3 to 4% in their lifetime. And then we know the truly high risk population are families in which there's a first degree family member and potentially more than one first degree family member, or one first degree family member and then one or more second degree family members. So second degree would be a grandparent, an aunt, uncle. Those are the would fulfill that category. And so I just want to share with you, when we're thinking through this high-risk population, we also consider not only the family history, but we consider the presence of a genetic mutation. So I'm just going to share a slide here that describes that. And in this slide, what you can see is that there are a number of genes that have been identified that are associated with an increased lifetime risk of developing pancreatic cancer. And they are included here on this table. So probably what many of you have heard most about are the BRCA genes. So BRCA1 and 2. These are in the middle category, the Lynch-associated genes, MLH1, MSH2, MSH6. We have the CDKN2A or Peutz-Jeghers genes that are also included here. And then we also have the ATM gene. And as you can see here, the estimated risk or cumulative incidence of pancreatic cancer in patients that are families with these germline mutations can be range between 0.5% and be upwards of 20% by age 70. And so that is why we consider testing for all patients who have been diagnosed with a pancreatic cancer or who have a family history of pancreatic cancer, because we're looking to identify these families so that we can use this information to guide surveillance and in order to identify early lesions and potentially curative care management. I'm going to just stop the share there. And so the next question that Dr. Phillip posed as well is not only the who, which is really important to identify, is then once we've identified them and once we've, our recommendations are always that, at our center, we're sending all patients with, as I mentioned, with a pancreatic cancer diagnosis for germline testing in order to identify the families and patients who carry these mutations. We know that we may identify a germline mutation in between 5 to 10% of patients who have a new diagnosis of pancreatic cancer. So we're looking to identify that patient cohort. And then once we've identified not only that group which has the germline mutation, or also just identified the group that may not have the mutation but has more than one first degree relative with pancreatic cancer diagnosis. Those two categories or cohorts or patients consist of the high risk population, and we then would guide them through what surveillance would be. And currently we utilize endoscopic ultrasounds and MRCPs to survey the pancreas. And what the data currently supports is utilizing these two technologies annually. So we alternate between the two. Question that many patients ask me in clinic is why these two? Many people have heard of CAT scans. There was and continues to be a great study called the CAP study, which initially evaluated these three different modalities and found that the endoscopic ultrasounds and the MRCPs were provided the most meaningful survey of the pancreas, and were able to reliably identify lesions of concern that would warrant further investigation. And we have since then determined that this schedule of annual surveillance has had an impact in overall survival for patients in this high risk category and identifying early or concerning lesions and resulting in investigation.
Thank you. We have several questions. Let's start off with one. At what age should we start the testing? So when you have someone who you think they're high risk based on genetics or otherwise, I mean, there are other predisposing factors for pancreatic cancer, from the chronic pancreatitis and hereditary, et cetera, but which is extremely rare. At one point do you start testing? But more specifically, in fact, the question is, I have pancreatic cancer and 2 teenage children. So the question is, for the 2 teenage children, at what age do you recommend that one consider starting the screening? And again, with or without the genetic testing?
Yeah, so the answer to those two questions is, from a genetic testing standpoint, most of the genes that we've associated with an increased incidence of pancreatic cancer in a lifetime really affects the adult population. So we would recommend cancer genetic counseling and potential testing, early 20s and older. Only in that some of the genetic mutations we may find are associated with syndromes that could involve risk of other cancers, and the incidence of those cancers could be at younger ages. So that's where the genetic testing, the timing or the age would be, we'd favor at a younger age group. In regards to the pancreatic cancer surveillance, the current data supports starting at age 50. So we would not start the endoscopic ultrasounds or MRIs until age 50 or 10 years younger than the affected family member at the age at which they were diagnosed with pancreatic cancers.
Yeah, I think that's the other question is, in colon cancer, colorectal cancer, we see nowadays a rapid rise in the incidence of younger patients who develop the disease. Do you think there is something similar happening in younger patients diagnosed with pancreatic cancer? And the same question also has a are these patients KRAS mutant or wild type, or do we know? So the younger patients. So the question is, are we seeing also the rise in the younger patients? And if so, what kind of is there any molecular difference between them and the common variety patients we see? And the average age obviously is 70 years.
Yeah, I think that the average age probably is lower than it has been. Unlike colon cancer, we don't have the same kind of surveillance guidelines and colonoscopies data to field from. So I wouldn't say that, I think that the depth of knowledge is probably greater from a colon cancer standpoint. And then I would say similarly in regards to the presence of KRAS mutation or wild type, I think that that work is still, again, under investigation. We don't have, again, the depth that we have in colon cancer, but I'll defer to some of my colleagues on the call if they feel differently.
Anyone wants to provide a comment on that?
I don't know if Dr. Osipov wants to weigh in, but there is some data recently published from Cedars-Sinai from the gastroenterology group. They're showing that the incidence of pancreatic adenocarcinoma in younger women in particular is going up, and the reasons for that is not known. And I think that would certainly be, again, the absolute numbers are not still very high, but the relative rate is increasing, especially in younger women. And it'd be very interesting to understand why that is happening. It's a puzzle at this point in time, much like young onset colon cancer is. But certainly one thing that's a measure we want to keep an eye on and figure out. It's not genetics necessarily. It's not associated with germline mutations, because that was not something that suddenly happened. Rather, it's something that certainly happened. So in the last, sort of couple of decades. So maybe it's diet, maybe it's other extraneous things that are contributing to it, but certainly something that we want to keep an eye on.
Okay, well, thank you. That's very helpful. There's a question to you, Dr. Perez. And the questioner, I have multiple family members that Dana-Farber is watching over for the ATM mutation. As my husband has pancreatic cancer currently in treatment with chemo, but has not been offered any specific targeted treatment for the ATM gene. Should he be? Obviously, this is more of a treatment question, and we will handle that, and we will keep this. I will keep this question to be also discussed later on. But can you just tell us very briefly ATM mutations? Because when we talk about pancreatic cancer risk, we talk about BRCA. I mean, that's what it is. But obviously, there are others. Just make a comment on the ATM so that people, because we see that also.
Yeah, definitely. I think that the ATM story is still unfolding. And I think the numbers very much are not solid from that perspective, but we do know it's playing a role. And so for a family, just as the person presenting the question, we are encouraging surveillance for our families with a pancreatic cancer diagnosis and ATM germline mutation, because we know that there is some contribution there. In regards to therapy, I think, again, just as we're trying to better define it from the genetic or inherited or the contribution to the development of the cancer, I think we're still very much trying to identify how to best to use that as a target. And I don't think that right now, unlike BRCA, it is not driving our therapeutic options at this point.
So Dr. Osipov, wait until you do your presentation, and then you're going to also handle this question from the perspective of treatment and what would be your recommendation for this situation, which obviously we were asked about. Any comments, Dr. Ashman? You also deal with a lot of newly diagnosed patients with your surgical specialty. Can you make any comments on? Do you see any differences, especially in the different ethnic populations in terms of the genetics, and we know about the linkage with the Ashkenazi Jewish heritage in BRCA, but you also work in Miami. Anything you want to comment on?
Thank you very much for the question. The reality is we all have a little bit of non-scientific appreciation that we're seeing some younger patients. It seems also that the behavior may be a little different. Sometimes they respond more to the chemotherapy, but there's going to be some time before we can be able to put it in a scientific way. The paper that was reported by Dr. Anriban a moment ago is the only one that I know of that speaks about increase in younger women. However, we do feel that we're seeing patients at an earlier age and in a little different presentation than in the past. Before, the majority of the patients with pancreatic cancers were patients that had lost weight, were very emaciated. Where now we see patients that we're even surprised that there was a discovery of a pancreatic cancer. In terms of ethnicity, I haven't seen any new trends other than the one that you mentioned.
Okay, well, thank you. I just want to finish off with one question to Dr. Perez, but all of you, I'd like you to join answering the question if you can. What about issues like access to genetic clinic, access to high-risk clinic, access or even insurance coverage of everything which we were talking about? Can you give us a feel of are these challenges? Again, remember, most patients will be going to their local hospitals, and what happens at Dana-Farber is not going to be anywhere reflective of what can be in Saint elsewhere in a mountaintop.
Yeah, I think that the companies are recognizing that. So there are genetic testing companies that are patient facing and that are collaborating or have hired genetic counselors on staff in order to counsel patients in regards to results. And so that has been kind of the means to try to open the catchment to more patients who may not have access to a larger center that has clinicians and counselors available to them. So I think that's one means to do it. We also are, there are many efforts in regards to cascade testing. So recognizing that there are families that are not all in one city or in the cities in which we have our counseling centers. We're working with some of these independent genetic companies to get testing and counseling to individuals across the country. And, fortunately, with things like this virtual medium, that is becoming more of a reality and more accessible to patients, and our ability to test using kits, getting saliva samples has also resulted in many more family members being able to get tested through this cascade mechanism. And I anticipate also just patients who are interested in getting testing who don't have access to a larger center would also be able to get tested by this means.
Thank you very much. And again, we go back
to
the issue of the education and the information that organizations like Lustgarten can spearhead in terms of getting things more known, because patients and caregivers also have to be really having this information, because a lot of people don't know. Sorry, Dr. Asbury.
Yes, thank you, Dr. Philip. I think that is a very important question, right? And it extends not just about genetic testing, but also about pancreatic cancer care. We see, at least in surgery, that the majority of the surgeries in the United States are being done in community hospitals, and the results are not always the same as the ones that are in high volume centers. It is a problem that we face, and I have to commend LustgartenLIVE Foundation by doing this type of media or education in general, to be able to see to a different population what other things need to be done.
Thank you. I think that's another great point. Dr. Ashman, since you made the last comment, then we may go back to you now to start the section which you're really leading. So surgery is a specialty, and there are several personalized treatments now out there. And when you consider those treatments for the patients you meet for the first time, so can you please discuss some of these options, the way you do it with the patients, and then I'll join you towards the end just to make a comment on one of the other treatments that we also want to talk about. So can you please go ahead?
Yes, of course. First of all, let me thank you and thank Lustgarten Foundation for this event. As we just mentioned, I feel that this just allows for propagation of knowledge and interaction, because we all learn from each other, even from the audience. I'm a surgeon, then I'm gonna be, as a surgeon, I'm always gonna say surgery remains the only curative treatment for pancreatic cancer. And that's still a fact. However, the times where the surgeon was the only one deciding if surgery needed to be done or not are all gone. As it has been explained before by Dr. Anirban, the multi-specialty care is key right now. And not only on the way that has been explained by you and him, but also even in surgery itself. Because what has happened is that we have been able to improve significantly the outcomes in surgery, particularly of the Whipple procedure, the pancreatoduodenectomy, that in the past was a very high mortality surgery. And today, in centers of experience and high volume, the mortality should be under 3%, 3-4%. But we have become to realize that we have not really improved the overall prognosis. And then this is when you all, and I mean the multi-specialty group, comes in. First with neoadjuvant therapy. It's well established now over the last decade that we have at least 2 excellent regimes of chemotherapy that have allowed us to do even more surgery on those patients that in the past we felt were non-operable, or what we call today borderline operable. And that term is related to how the tumor relates to the different structures. Then currently, as in any of the other panelist centers, each patient is discussed in our multidisciplinary tumor board, and we make the decisions accordingly. Now, the multi-specialty group is also important from the point of view that complications in surgery are going to happen. Even if you are the best pancreatic surgeon in the world, you will have complications. And that was a very difficult concept for us to accept. But we realized so about 10, 15 years ago, and then we put our efforts in trying to improve the way how we treat the complications. And today, our best allies are our multi-specialty group. Why? Because we have what we call our rescue team, meaning after the big procedures we have had, the complications that before were lethal, today those complications are not lethal anymore in the majority of the cases, because we know how to treat them better. And for that, we need interventional radiologists, interventional gastroenterologists, etc. That is from the general point of view of surgery. In terms of techniques, we have improved significantly the experience for the patient, meaning we do now minimally invasive surgery, either through the robot, which is a term that everybody likes, or through the laparoscope, meaning the minimal invasive access. And that has helped us not only to just cut the hospital stay for a day or two and do small incisions, but also to have better access to difficult areas. The magnification is great. And even though it takes a significant amount of commitment to be able to become an expert or at least proficient in these techniques, once you do this, then there's no question that there is a major advantage for the patients, especially for the left-sided pancreatic tumors. In terms of other things that we do during surgery, we're using fluorescence to try to differentiate the different tissues and to make sure that we do a more oncologic resection. And we're testing in a variety of other types of techniques. But as I mentioned before, we are pretty clear that we will need other treatment modalities to be able to increase the overall prognosis and survival on patients. And this is what has been happening. What are the treatment modalities we have? We talked already about neoadjuvant chemotherapy. At Miami Cancer Institute, we started doing what's called the MR-Linac radiation that now many of the centers across the country are adopting. And that is basically doing radiation therapy under MRI live, because as you all know, the traditional radiation is done with some measurements, fiduciaries over a CT, and then the treatment is given throughout the treatment period based on those initial images. The MR-Linac allows to give radiation during under MRI live. What it does is then that the tumor, when breathes and moves out of the target area, the machine stops the radiation. When the tumor comes back into the target area, the machine starts immediately and does radiation. Also, since it's done under live MRI, the variances of where the intestines are one day and the other are clearly noticed, and the treatment is varied and adapted to where the bowels are that day. The end result is that allows you to give ablative dosage, meaning higher doses of radiation, because it's much more targeted. And we have seen at least better responses on some of the patients that before were considering borderline surgery that have allowed us to do surgeries. Another modality is IRE. IRE radiation, actually IRE is not radiation. IRE is has been performed now since 2009, then it's not that new, but in the past was done only during surgery, and now is done also percutaneously, meaning without needing of surgery. And what it does is it does not rely on thermal base necrosis, but on high voltage. Then the voltage that's around 3000 volt in pulse lengths, and what happens is it induces permanent cell damage, at least by porosity, which leads basically to cell death. Interestingly enough, on patients that are non-operable, we have been survivals that in the past would have been felt unbelievable. We're talking in the range of 3-4 years. Still, the disease ends costing the patient's life, but the survival is better and the side effects are minimum. It is basically used for palliative care. We also have done intravascular chemotherapy, but that's only under trial. And these are with catheters that go inside the arteries around where the tumor is. And there's a balloon proximal and distal, meaning at both sides of where the tumor is. And then the chemotherapy is delivered directly into the area of the tumor. Different than liver tumors, doesn't access the arteries that go to the tumor, because these tumors have multiple small arteries, but it accesses the area, and by permeability of the vessels, the chemotherapy is delivered directly into the area of the tumor. Then it's a fascinating field. I feel that Dr. Anirban has shown the passion of all the changes that are happening, and Dr. Perez is showing us what, to me, it's going to be the future of the treatment of pancreatic cancer. I don't need to explain what Dr. Perez can explain much better than me in regards to the fact that we're probably dealing with multiple different cancers that we call it pancreatic cancer. And when I say multiple different, is because the behavior is quite different. And as we learn more on their molecular composition, we will be able to have a much more target therapy and be able, in my view, probably to do surgery in much more patients. Ideally, one day we will need to do surgery, but I think we're still far away from that. At least I have to say that out of job security.
Yeah. Well, thank you very much. That was really, very fascinating. And just to pick on something you said, I believe in personalizing treatment, but I go beyond the molecular. It's a personalizing treatment where every patient, we really determine what is the best path or strategy of treatment. And again, it goes beyond doing blood tests or scans or anything like that. And I'm glad that you're bringing that back, as we've been saying today, the multidisciplinary treatment, as multi-specialty treatment, because no two patients are the same, as you and I very well know. But let me add on something to what you said. I mean, what you were talking about is the different ways to have a better control or even eradication of the cancer locally. More recently, there's work which has been done, it's been for a while, but now it's coming to pancreatic and other cancers, is the concept of tumor treating fields, which is not radiation therapy. It's a non-invasive, it's a local regional treatment, giving it to the tumor itself. And in fact, the tumor treating fields concept has been approved now for a number of years for the treatment of glioblastomas. It was approved by the FDA, and it really works by delivering the low intensity, intermediate frequency alternating electric fields to the tumor from the outside. You're not really cutting anything, and you're placing transducers on the surface of the skin, which will be delivering the energy. The energy source is a portable little machine but battery operated, which really allows the patient to do their daily activities. And the side effects are mainly mild to moderate skin irritation, as you'd expect. The way it works is by disrupting the mitotic spindle and mitosis and other changes that lead to apoptosis. And I have to say that there was a recent completion of a phase 3 trial in combining tumor treating fields plus chemotherapy in patients with locally advanced pancreatic cancer, frontline treatment with survival being the primary endpoint. So I just wanted to add this piece to, as we improve our systemic treatments, as we make systemic treatment better, we have to really focus also back on how we make we control the disease better in the pancreas area. And Dr. Aspen, you talked about some of the things you're doing. I want to give you a minute, a maximum 90 seconds, to really tell me about what is your view of, as a surgeon, of the use of neoadjuvant chemotherapy versus preoperative chemotherapy versus adjuvant chemotherapy, which has been for a long time the standard of care. How do you manage that, and how do you really deal with that with your patients?
I think that the majority of the high volume centers, at least surgeons, have been leaning more towards doing neoadjuvant therapy. Initially, we all thought we cannot lose the opportunity to do surgery on these patients, and if the patient is resectable, we should just jump in and do surgery. By now, we need to be more humble. This is now my personal opinion, not scientific. We're doing a surgery where 70% of the patients are going to have a recurrence. Then we're missing something. And chemotherapy, now that we have improved regimes, plus all these other radiation ablations and everything else that can prolong a patient's life, are also an option. And on patients that are going to have the tumor grow on neoadjuvant therapy, that is telling us that the tumor has a really bad biology. It is aggressive. And it makes us think that those are going to be the patients that are going to have a recurrence regardless. Then I think that neoadjuvant therapy now, it helps us what we all know, that it is reduce the size of the tumor, control any potential cells that, or hopefully control, I should say, cells that are running around from the very beginning. And it gives you a sense of confidence that if the tumor has responded well to the chemotherapy, then we have a little better of a biology. At least we have better tools to fight with this disease that in the past has been so frustrating to fight for.
Okay. I want to ask you two questions, and I think we're running a bit of a bit late, not too much of it. One question is a yes or no. Would you use or would you recommend the MRI LINAC treatment to be done? Can it be done after chemotherapy? I guess it can be done anytime. Am I correct?
Correct.
Yeah. So there's no, but it should be disease mainly localized in the pancreas. The other question to you is, it was our first question we got today actually, but I kept it for you. When you treat patients, let's say you would remove the cancer and you're following them up, do you use DNA test, blood testing? And the question is specifically a Signatera DNA blood test. Is that something you routinely put as part of your follow-up for the patient? Again, yes or no?
Yeah, well, yes, if the insurance allows us. That's a reality that we have to live with.
Okay.
And my hope, and this is adding to the yes, is that one day we're going to be doing CTCs, circulating tumor cells, because those are the ones that have been proven to show us the earliest sign of recurrence.
Well, thank you very much, Dr. Assman. This was terrific. Now we go to Dr. Osipov. So we get asked a lot, Dr. Osipov, about the multidisciplinary care. Can you give us a sense of what this entails at Cedars-Sinai? And then I'm also really excited to learn more about the promising translational research that you and your team are leading at that institution. And we have one or two questions that we heard about the ATM, how we treat ATM, for example, and what you're doing for that. And we also have a question about immunotherapy. Specifically, the question addresses Keytruda or any other immunotherapy, and what you think in metastatic disease, but also in patients after surgery, because the question is also talking about after surgery. So Arsen, go ahead, and we have like 10-15 minutes.
Thank you, Dr. Philip, and thank you again to Lustgarten for inviting me to speak. I mean, these are all great points and great questions. And as Dr. Mitra initially mentioned, and Dr. Perez and Dr. Osman, I think all of us have this mentality of true multidisciplinary care. I think for any individual patient, having experts from every discipline really does improve their care long term. Here at Cedars, one thing that we've done is, oftentimes this care, even though it's done as a multidisciplinary team, can be somewhat even disjointed. So what we've done is we've created a same-day clinic where in the span of 4 hours, all disciplines, including all ancillary services, social work, palliative care medicine, genetics, research, clinical trial, enrollment apparatus, they all come together around the patient in one clinic room to be able to deliver comprehensive care. And we obtain samples for genetic testing, both of the germline, inherited genes, and as well as somatic testing. And Dr. Aspen had mentioned how important molecular profiling really is, and will probably be even more so in the future. And it really does help us kind of figure out how to best approach these patients, both even from standard of care and as well as for clinical trials and how to improve outcomes for these patients. Now, I do want to show one slide. I think it'll really help understand about the molecular profiling, which in our multidisciplinary care, we feel is very important, to have the input of a molecular pathologist and to use the genetic information of the patient to guide their treatment. So let me share a slide here. Hope the team, everyone could see this. Here, you could see, we talk about, as we've mentioned, and Dr. Perez had mentioned about doing germline testing, but also doing somatic testing, which is taking the tumor sample and understanding its genetic code. And we know that about 90% of pancreatic cancers have what's called a KRAS mutation. This is the mutation that really drives the cancer. But at that same time, there are 10% of patients that don't carry this mutation, and they behave biologically different. It's an important subset. And we talked about age, for example. We know that patients that don't have a KRAS mutation tend to be diagnosed about 10 years younger than those that actually carry the more common mutation. And as it stands now, often the backbone therapy that Dr. Mitra had mentioned, it really is the mainstay for these KRAS mutated tumors. But these KRAS wild type or non-mutated tumors, they often have very unique mutations that happen sometimes 5-fold higher than those that have KRAS mutations. For example, these patients may have unique mutations that confer sensitivity to immune therapy, such as having high MSI, high TMB. This happens 5% of the time, whereas with KRAS mutated tumors, it happens only 1%. Sometimes they have mutations like BRAF. Now, this is a mutation people hear they associated with melanoma, but now we have trials even in pancreatic cancer, even here at Cedars, where if you have this mutation, you get a direct targeted therapy and not chemotherapy. This happens afterwards. And we've seen that patients actually can have long and durable responses. So this slide just really does highlight that there is a molecular approach to really identifying these patients and figuring out what's the best pathway. Now, sometimes we may not have a direct targeted therapy, but it also helps with enrolling them into clinical trials, which is a very important part of multidisciplinary care for these patients. It's important part of the Lustgarten Foundation and their support for clinical research. So the second part that was mentioned was really about immune therapy. Now, oftentimes I get asked this in clinic, as I'm sure all of my other esteemed colleagues do as well. They hear about the successes that happen in lung cancer and in melanoma, and they say, what, doc, how come I can't get immune therapy? Why are we not trying to, Keytruda or other forms of immune therapy? Well, there's a few reasons behind this about why we have some challenges in pancreatic cancer. So the environment of pancreatic cancer, the tumor environment, is not really conducive to the immune system. In other words, it's like a fortress. It doesn't allow those really good immune fighting cells to get in. And there are many reasons. We know that pancreatic tumors don't have a lot of those good effector T cells. These cells are really necessary for immune therapy like Keytruda or checkpoint inhibitors to exert their effect. On top of that, they actually have kind of a wall around it, this dense stroma. It's like a shell almost. It doesn't allow even chemotherapy or immune cells to get in. And on top of that, we have these immunosuppressive cells. And these are all serve as barriers as why just trying a single checkpoint inhibitor like Keytruda outside of having a very specific biomarker doesn't really confer benefit. And this has been shown in multiple clinical trials. Now, that being said, I want to show that the tumor microenvironment is a very complex place. There's all these constituents that really can impact the response to immune therapy. So our thinking, along with Lustgarten and a lot of institutions throughout the country, is how you take single checkpoint inhibitors and how do you make pancreas cancer sensitive. And one of the ways we found is there are many immune suppressive components in the tumor microenvironment that may block the effect of immune therapy. So by targeting them, we can sensitize the tumor to immune therapies. And I'll give you a few examples. This slide highlights them. Now, for example, there are these proteins, or they're called cytokines, which can influence immune cell populations. There are cytokines for IL-1, IL-8, and we know that by targeting these through drugs like nadunolimab, as well as newer drugs such as interleukin 8 targeting, you can possibly make immune therapy work better. So we're finding that combination strategies are a good approach. Now, that being said, we had talked about germline mutations. I know that Dr. Perez had mentioned this, and this is also an important part of it. Now, we know that that germline mutations really can happen in patients where they have a higher risk, but at the same time of having a higher risk of pancreas cancer, it may actually confer sensitivity to certain drugs or certain chemotherapies, like drugs that contain platinums, for example, oxaliplatin and FOLFIRINOX. But at the same time, recently in patients that have had germline mutations, there's been an approval of PARP inhibitors in the maintenance. So there's a lot of new translational investigations we're doing, looking at combinations of PARP inhibition plus immune therapy to see if you can sensitize these tumors more. Now, these drugs, again, comprise generally adjunctive agents or agents to sensitize to immune therapy. And they come in many forms. You might hear about studies that contain checkpoint inhibitors, which are your standard kind of immune therapies, but we also have small molecular targeting. And this is really important for targeting even the most common mutation. So for example, KRAS. So KRAS is really considered the holy grail. And we're on our way to that path, where there's a lot of preclinical studies where these small molecules that have been created to target KRAS are showing promise. For example, recently, there was a drug, sotorasib, that was shown to show benefit in patients that have very specific KRAS mutation, KRAS G12C. But now we're looking at the more common KRAS mutation, which is G12D, and there are clinical trials and preclinical studies showing benefit of potentially targeting these through a small molecule. At the same time, there are trials happening across the country looking at vaccines, specifically targeting KRAS, both even in the adjuvant setting and in the metastatic setting. So this slide is really meant to show that there are multiple constituents in the tumor microenvironment that can be targeted through various mechanisms to sensitize this tumor to immune therapy, such as Keytruda. I know that was brought up previously. And here at Cedars, we focus on kind of novel approaches to not only understanding the biology of these tumors, but also how do we translate this into a clinical benefit. And one way we're doing this, and this is an example of a clinical trial that's supported by the Lustgarten Foundation. This is a very unique neoadjuvant platform in order to test these novel combination immunotherapy drugs. So, we know that single agents don't work, but here we're showing that if you combine them in the space before you get surgery and after you get potentially even neoadjuvant chemotherapy, we can see if these exert an effect on the tumor that Dr. Osman may resect and understand the biology, and also test even long-term, do these patients respond by keeping them in the maintenance phase. And here, for example, as time goes on, and the unique part of this, it's a platform. So we can just add new arms that are showing promise in the preclinical setting. So for example, here, we're looking at CXCR1 inhibitors, which focus on these immunosuppressive neutrophils, and then IL-8, again, it's a cytokine that's considered to be immunosuppressive. So we believe by targeting them, we can sensitize it to anti-PD-1, which is an example, again, for Keytruda. And here at Cedars, we have trials similarly in this setting where we're doing neoadjuvant immunotherapy-based combination studies. So these are just some examples of how we're taking translational science and trying to apply it to a drug that we wish would work even better in pancreas cancer, such as immune therapy or checkpoint inhibitors.
Thank you, Arsen. This was fantastic. And again, what you're doing is you're trying to truly translate biology to clinical care. And hopefully you go back when things don't work as well, or even if they work, to understand whether you're really doing the same thing in patients. Here you're not going into just blind empirical targeting one molecule or another, but you're putting a lot of effort in designing studies that really follow the biology of the tumor. The question, I remember, you had the question of ATM mutations. I'm giving you a couple of minutes, one for the ATM mutation question. Do you treat those patients? And the other question is, would you use Keytruda, and when would you use Keytruda? Because this is a question which we were asked, and then I'm trying to make it a bit simpler on you. So when would you use Keytruda, and do you treat ATM mutations?
Yeah, so we'll start with the Keytruda question. In general, most pancreatic cancers, as a whole, they're not very responsive to single agent checkpoint inhibitors. So typically, when we use it, are two circumstances. One, in the context of a clinical trial, regardless of the stage of the disease. And here we have examples where we combine Keytruda with, for example, a FAK inhibitor, which is a tumor microenvironment modulator. So in those cases, we definitely use it. Or checkpoint inhibitors combined with PARP inhibitors, and there are countless. The other time where we use it is if they have a very specific biomarker, as I had shown. So for example, tumors that are KRAS wild type and maybe MSI high. So based on the genetic profiling, if it tells us that likely this patient will respond to checkpoint inhibitors, in those cases we will do. Outside of that, it's usually in the setting of a clinical trial that I'd recommend.
Okay,
And then to the question about ATM, I know that Dr. Perez highlighted this as well. You know, ATM is a little bit of an unusual mutation in the sense that it's somewhat still in the class of mutations that affect DNA damage repair. Now, the common ones, you know, BRCA1, BRCA2, we know they really confer sensitivity to PARP inhibitors. This is still an area of investigation. And if the mutation is carried in the germline, there is some data suggest that they may respond to PARP inhibitors or platinum-based therapy. But again, I would defer these patients to go into a clinical trial where they may get one of those drugs, such as PARP inhibitors or platinum-based therapy. It doesn't change our thinking too much as we still continue to investigate this mutation.
I agree with you. I think the evidence at this point in time, still not, we don't have good evidence, and clinical trials would be the right thing to do. Well, thank you, Dr. Osipov again. And before we close with our final thoughts, what I'd like to do is, again, we're thinking of the future. I think it's exciting as we talked about. There's a lot happening. There's a lot of research which is really feeding the pipeline to the clinic in terms of ideas and also what to do in the patients. We have clinical trials. There are many clinical trials around. So I really want to go back to Dr. Mehta and really ask you, can you tell us more about the Cancer Moonshot that you're involved with? Can we hear a bit about it? Because that will be something which I think everyone, including myself, are very eager to know.
Sure. Thank you, Philip. So I think, you know, the Cancer Moonshot, as you know, was initiated in 2016. And earlier this year was subsequently, as I say, reignited as sort of Moonshot 2.0. And I think there's a lot of very important initiatives that are germane to pancreatic cancer that were funded initially through the National Cancer Institute as part of the earlier iteration of the Moonshot. What is very important for this 2.0 version that the president released through the White House recently was that it really brings the focus back on early detection and prevention. In fact, just last week, the NCI released what they call the National Cancer Plan, or NCP, for the first time, kind of, you know, sort of our broad roadmap to making progress against some of the deadliest cancers. And it was wonderful to see prevention, early detection, and this other term that I want to introduce called cancer interception, which is to stop cancer from happening, and kind of like an interception in an NFL game, in a football game, and maybe even take the ball the other way, like a pick six. So basically revert the changes, abnormal changes that are happening in the pancreas. So cancer detection, prevention, and interception are at the very top of this National Cancer Plan, which was released as part of this reignited Moonshot. So again, there is no question that, you know, we have seen a lot of progress in pancreas cancer, but the greatest progress, and I'm a firm believer in this, has come in the subset of patients who were diagnosed earlier in the process and then were able to get therapy and undergo surgery. So again, you know, going back to what Dr. Asban said, getting our patients to our surgeons is probably one of the most important things we can do in terms of outcomes, improving their outcomes, and therefore earlier detection of this disease becomes paramount. And that's why, coming back to what Dr. Perez said, identifying who's at high risk, how to screen them or do surveillance on them, and then those who have early stage disease, get them to our surgeons, represents for me the most important roadmap for pancreas cancer for improving survival. Right now, only about 15 or 20% of patients are able to undergo surgery. If we can move that needle from 15 to 20% to 50% or greater, we will have more impact on the survival of this disease than any drug that's currently available. So to me, that's, I think, priority number one. I am going to say that the excitement that's in the oncology community right now focuses, and I think Dr. Osipov mentioned that also, is in terms of all the drugs that are coming in terms of targeting KRAS. In 3 years, I think every patient with pancreas cancer is likely to have at some point in their treatment a KRAS inhibitor that they will get. And so these drugs are going to be part of an oncologist armamentarium. I hope I'm not misspeaking here, Dr. Perez and Osipov, but I think these drugs are going to really change the landscape of therapy in this disease. Obviously, they alone will not be enough. We already know that treatment resistance develops. They have to be used in combination with other drugs, including immunotherapies. But here's where we're excited that immunotherapies haven't really worked very well, as Dr. Osipov mentioned, but in combination with RAS inhibitors, we're really hopeful. And again, there's a lot of research and clinical trials ongoing. So to me, these are the two sort of big areas that I'm excited about. And again, the Cancer Moonshot and the National Cancer Plan really has brought early detection, prevention, and interception to the top of our priorities. Before I forget, I did want to mention one more thing about cancer interception. And again, the Lustgarten Foundation is quite heavily involved in this. For the first time, we now have the very first trials in using a vaccine to prevent pancreatic cancer in high-risk patients. This is ongoing at Johns Hopkins, and hopefully this is the first of many trials that will happen in terms of preventing cancer. And I think you've all seen how cancer vaccines can prevent, for example, cervical cancer or liver cancers. This is the first time this whole approach has come into pancreas cancer. This is right now restricted to a very small subset of patients who are at the very highest risk, but we are hopeful that we can expand these sort of vaccine trials that will again intercept cancer from happening in somebody who is at risk for this disease. And again, using the football analogy, pick six, take it the other way, and really bring it back to baseline. So I think this is what we are very excited about.
Thank you very much. Thank you. Just a quick question. Someone's asking which agency is running the Moonshot? Is it NCI?
It is the NCI. Yes, the NCI is running the Moonshot, and as well as the National Cancer Plan. Of course, the White House's Science and Technology wing is also heavily involved in it, the OSTP as it's called. But really, it's been administered through the NCI.
So, I mean, we spent not too much time. It just everything passed so quickly. But I think all of you would agree, if we had this meeting 20 years ago, it was going to be a very short meeting. But I can assure you that we can spend another 3 days discussing because there's so much out there. So just to give you an idea, like I'm confident saying that six of us can spend another 3 days and just talk about it. There's so much there to talk about, but unfortunately we can't. I think Andrew is just telling us like our time is up. But before we really completely log out, let's go around and just ask all of us, so actually including myself, what is the thing that really excites you, and especially with relation to the work you do? We can do this in 1 or 2 sentences, and we'll start with Dr. Perez this time.
Thank you. Yeah, I'll be quick. No, I think this is a really exciting time in pancreatic cancer, and I have the benefit of seeing patients in the high-risk setting as well as with my medical oncology hat. And as a clinical trialist, it has just really been a rewarding time to work with all my colleagues on this webinar, as well as others across the country, to move things forward. And I think the availability of technology, vaccines, and targeted therapies, RAS inhibitors, is just, it's an exciting time. And I think we're going to see a lot of movement forward over the next few years.
Thank you. Dr. Asper?
Well, you asked what excites me. I am very fortunate that I work with my hands, and I am passionate about what I do because I like it. And at the same time, I can make a positive difference for my patients the large majority of my times. That's what excites me. In terms of pancreas, and the reason why I said that is, in pancreas cancer was very difficult to feel we were making progress. And as you have very nicely emphasized today, the field has changed. And for several reasons, but one that we cannot ignore is because finally there is more support, resources, money put into pancreatic research. Before, pancreas cancer was something that no one wanted to talk about. Now it's becoming one of those that we're supporting. And that's why I want to thank all of the potential donors and Lustgarten for doing what they're doing. I've done this enough that I can say we're finally making a difference.
Thank you very much. Thank you. That's great. Dr. Osipov.
Yeah, thank you again, everyone. I would say one of the things that really excites me is that just the sheer volume of translational research that's supported by great institutions like the ones that my colleagues are from, as well as from Lustgarten, it's just increased by many factors. And that translational research, where we can take information from the lab, translate it to something that can hopefully be effective for patients, and take that same information and go back and learn even more, is really, I think, pushing the needle of science forward. And to highlight that this is really done in the context of a comprehensive team, not just with foundations and hospitals and physicians, but with patients. They are an integral part. And I think that together and how that's grown over the last 10 years since I just finished medical school, I'd say that's very exciting.
Yeah. And again, Andy, you want to say something before I finish up with my thoughts?
Yeah, no, and I'll let you have the last word, Dr. Philip, but thank you to everyone for being on. And Dr. Philip, you joke we could spend 3 days. I think we spend 3 days or more several times throughout the year at different meetings talking about all that's going on. And it is such an exciting time for pancreas cancer research. And I'll just reflect a little bit what I heard of what's making a difference for patients today is one, I think changing the way we think about care. And I think that where we started on thinking about multidisciplinary clinics. And as you very elegantly said, Dr. Philip, thinking about the patient first and treating the patient as a whole and what they want to achieve. But as everyone here has pointed out, what's really been exploding in terms of research and how fundamental understandings about the biology of the disease, whether it's who's at risk that enables us to put people into screening and surveillance, what are the mutations that are driving disease and how we can use targeted therapies, really understanding all the tricks that the tumor uses to avoid the immune system and how to bring in combinations. Those are all things that are possible because of fundamental understandings about the biology. And it's amazing to have such a dedicated group of scientists, clinicians, and everyone here on this call, the clinician scientists, that bring that together and are, act as urgently as the patients need to bring the research as quickly as possible to the clinic. And it's something that Lustgarten is obviously committed to and will continue to drive as fast as we can.
Thank you very much. And again, for me, I would like to finish off by saying thank you for everyone. But before I go thanking everyone, including Lustgarten, I would like to say that it's really clear that the patient's journey after the diagnosis of the pancreatic cancer requires strong collaborative team of specialists that also includes, in addition to the pathology and on the traditional multidisciplinary people, I'd like to say it again, I strongly feel that the scientists and the molecular pathologists should be the integral part of it. And I've been in tumor boards, some select tumor boards where they are, and we talk about things like taking cells out, putting them in organoids and things like that, but an area which you can think of that can be expanded. And again, the scientists are very, very important. And again, we're very excited that there's a lot happening and the translation is accelerating into the clinic. And that's something which we want to know. But we also have to keep in mind that the vast majority of the patients are under their local care and they're excellent physicians there. So we need to really get that message there to also educate, empower the patients, because if they know more about their patient, their treatment, their disease, they can also be in a better shape to be treated and ask the right questions also to the doctors they're really dealing with. With that, thank you very much, everyone. It's time for me to go back to my clinic, and I will let Andy or someone to say the final word. Thank you. Thank you, Lustgarten. This was a great opportunity, not only for us to get together, but also to be able to give you, everyone attendees, our opinions and how we feel. And you can see that it's really a very positive one.
So thank you, Dr. Philip, for an excellent webinar. And thank you to the whole panel for being here, taking time away from your very busy clinics where I know you're very dedicated in driving things forward. But we appreciate you taking the time to speak with everyone here. And it's very important information for folks to have. And a special thank you to Miami Cancer Institute, Baptist Health South Florida, who sponsored this webinar. And for those who might be joining us for the first time, LustgartenLIVE is something that we repeat several times throughout the year, highlight different activities, different things going on, different research advances. Our next one will be taking place mid-June, where we'll be celebrating Juneteenth and talking about disparities and inclusion in cancer care and cancer research going forward. So thank you to the panel. This was wonderful. Thank you especially to all of the participants and the patients and the families and caregivers. You're the ones who we're really here for and who make this possible.
Thank you for having us. Thank you.
Thank you.